Here is a case of phacoemulsification of dense brown cataract with pseudo-exfoliation and phacodonosis. I started with 2.4 clear corneal incision. Then you can see a difficult opening of the anterior capsule by the cystatome with present of prominent anterior capsule stria, thromboleaning, which are signs of zonular weakness. Also, you can see here the pseudo-exfoliation at the white arrow. Finally, the anterior capsule is opened. Then I completed the capsulorhexis using the capsulorhexis forceps. Here you can see a well-centered and well-sized capsulorhexis. Before doing the hydrodissection, I empty the antechamber. Then here is the hydrodissection with gentle hydrodelineation. Then I started with horizontal chop technique to chop this dense nucleus. And while chopping this dense nucleus, the pupil starts to constrict. And also you can see the iris is floating in the antechamber. It was slightly difficult to emulsifying this dense cataract because all of the capsular bag is moving because of the weakness of the zonule. And also you can see the hydration of the conjunctiva, ballooning of the conjunctiva by the BSS, as my paracentesis and phacoincision are close to the conjunctiva. So the fluid passed inside the conjunctiva make ballooning of the conjunctiva. Actually, the ballooning of conjunctiva affecting the field of view. Here it's very clear the ballooning of the conjunctiva from the BSS. I filled the antechamber with viscoelastic. Then near the paracentesis and the main phacoincision, I did a small incision in the conjunctiva, trying to empty the fluid from the conj. Now using bimanual irrigation aspiration to remove the cortex. Look at the capsular bag. The whole capsular bag is moving while cortex removal because of severe global zonular weakness. It was difficult to remove the cortex as it's stuck with the posterior capsule, so I implant a capsular tissue ring using the bimanual insertion as it's clear to support and to stretch the capsular bag. Also, removing the cortex after implantation, the CTR, is slightly difficult as also the cortex is stuck with the capsular tissue ring. I'm trying to remove the cortex. Because of severe global zonular weakness, the IOL implantation here should be 3 pieces IOL, and I choose to use the haptics in the sulcus and optic capturing the capsular rhexis. By this technique, I can provide long-standing stability and centration of the IOL. Finally, washing out the OVD anterior and behind the IOL, and be sure that the IOL secured inside the capsular rhexis. Then stromal hydration of the incision. And thank you for watching.